So for prosthetic valves, that's something that we see often, and I think that for sonographers and for readers that are reading the study, it's always met with a little bit of trepidation. Um, One of the things that we try to do is take their fears and walk them through each part of the exam. Just because you have a prosthetic valve, it actually doesn't change any of the workup for the equations that we use, such as calculating how much the valve opens, which would correspond with the valve area. Same thing for the corresponding gradients across the valve. So in terms of prosthetics itself, sometimes the challenges that we face is that we don't encounter them as much as we do for the native valves that are non-prosthetics. Sometimes shadowing itself from those valves make it harder to see leaks around the valve. That's something to be aware of. Some of the things that we teach the sonographers are to keep sweeping through the valve and to be aware of those pitfalls so we can catch them. And then there's some other techniques that we use for evaluation of a prosthetic valve that are a little bit different from a native valve. We also pair the senior sonographers with the junior sonographers and the students, all on kind of like on a hierarchy. So with more experience, you're able to teach one, and then once you become a senior sonographer, then you kind of keep moving down, and you'll be teaching the junior and the students. So we can kind of pass that experience around. And then we also have protocols specifically for prosthetic valves in that evaluation that we use when evaluating those valves. So when we're looking at valves, the two-way that we look at valves is we break it down to either stenosis or regurgitation. When you have prosthetic stenosis or any type of valvular stenosis, there's a problem with the valve opening. Regurgitation is a problem with the valve, in a sense, closing. Specifically for stenosis, the way that we interrogate those valves is with a Doppler ultrasound. It's a physics principle, and we're able to actually look at the gradients that are corresponding across that specific area of interest. We'll get a peak gradient, a mean gradient, and a velocity, and all those parameters correspond to, in a sense, how well the valve can open. So those are some of the main features that we look at. The other thing that we also do is we compare those Doppler ultrasound principles from one echocardiogram to the one that was done at baseline. So, for example, if we have someone that had a valve, the first thing that we actually want to do is see what the gradients were across that valve at, basically time zero or day one, preferably not when they were under anesthesia. And then if there's a big step up in the gradients across the if there's a big step up in the gradients across the valve, then we know that there's a marker for some type of structural valve degeneration, is what the term is called. And then we continue to either monitor that patient, or in specific times, we actually would need to replace that valve. From those Doppler signals, we're also able to calculate the aortic valve area. And again, we're looking and seeing how much of a change in gradient that we have across that valve. In terms of regurgitation, we want to separate central or regular regurgitation from paravalvular leaks, as you mentioned. The definition of paravalvular leaks are leaks around the prosthetic valve itself, and that comes around the struts. That's in contrast to a central prosthetic valve leak, which is really coming from the middle of the valve. The difference between the two that's important to note is that paravalvular leaks are usually seen on the day after surgery or the day after the transcatheter intervention. There's not much we can do about them. Usually that's from calcium. Sometimes that's from how we suture the valve. or the angle that we suture the valve, as opposed to the central leaks. After wear and tear, you can imagine that the leaflet itself will wear down, and if it just doesn't close correctly, then it can, in a sense, be broken, or what we call a flail, and that can cause a significant amount of regurgitation, and that's when we would replace that valve. So the sonographer is in a sense, the first person that's going to encounter the disease in question. Their job is vital to the team, because in a sense that's your eyes on the ground. That's the person that, if they don't pick up that subtle abnormality, then they can't focus in and allow us to make the appropriate diagnosis. I think that the rapport that we have with them is great and strong, and the education that we provide them really lends it to, so that when they're doing a study, if they have a question, they can actually ask us in the middle of the study, or after the study. Sometimes they'll go back and with more information and more understanding of the pathology, so they can get a better grasp of what's going on with the case. Again, going back to protocols, they go over specific views, so we can not look at valve disease in one or two dimensions, but in multiple dimensions, so we can correspond everything that we're seeing and make a picture that makes sense, rather than something that we saw in one particular view and not seeing in another. And that's the main way that we have a good dynamic and rapport with our sonographers. Yeah. Yeah, so they're sonographers through their for continuing education. They One of the things that we have, at least in South Florida, from a national and a local scale, is our echocardiography and structural heart symposium. This is going to be our 41st year doing that event. And what I like most about the event is the diversity of our audience. So the way that each section is the way that each section is broken down is that we start from the ground up. So we'll take something, and we'll something like aortic stenosis, mitral valve disease, or tricuspid valve disease. We'll start from the basics and start building upon that to more and more advanced concepts. Sonographers actually speak during this conference, and they are a key role to make sure that everybody kind of understands those nuances with the workup of the disease. I think that when clinicians or cardiologists, speak about these diseases, I think that sometimes they may go a little bit too fast and not go over some of the things that we may have forgotten, which are the basics of workup of valvular heart disease. So the conference itself looks at it from multiple different views, from the sonographer, from the general cardiologist, from the imager, and even from the person doing the procedure. And what's nice about this year is that we've actually added a section for surgeons to attend and give a talk about how they would replace it from the surgical aspect. So it's a nice way and a nice, well-rounded audience. I think that some of the other conferences are also great, but they either focus on the sonographer or the cardiologist or the surgeon, and this one brings everybody together. So it's kind of neat that we're able to do that.